I guarantee you've seen this patient in your pharmacy. They come in describing this profound, life-altering fatigue that just never goes away. We're talking about myalgic encephalomyelitis, or ME/CFS. It's incredibly complex, it's often misunderstood, and today we're going to give you the essential knowledge you need to really support these patients.
So here's our game plan. We'll start with what this illness actually is. Then we'll touch on how it's diagnosed and what the goals of care look like. After that, we'll dive right into our sweet spot, both non-pharmacologic and pharmacologic management. Before wrapping up with some key counseling points you can start using at the counter tomorrow.
Okay, first things first. We have to be super clear here. The fatigue in ME/CFS is not the kind of tired you feel after a long week. It's not something that a good night's sleep is going to fix. It is a severe, disabling exhaustion that literally changes a person's ability to function in their daily life.
This quote right here gets to the heart of it. It describes the single most important, defining feature of this disease, what patients call a crash. And it can happen after even the smallest bit of effort. This isn't just feeling tired, it's a whole-body system failure called post-exertional malaise, or PEM. And honestly, PEM is what makes ME/CFS ME/CFS.
Think about it. Any kind of exertion, physical, like walking to the mailbox, or even cognitive, like focusing on a long conversation, can trigger this crash. You might have a patient tell you that one trip to the grocery store put them in bed for 3 straight days. That is PEM. It is the absolute hallmark symptom of this illness.
So what causes this? Well, as you can see, we don't really have a single simple answer. It's a multi-system disease. We know it can be triggered by infections. You see things like Epstein-Barr or even SARS-CoV-2 on the list. But it also involves the immune system, metabolism, even environmental stuff. This complexity is exactly why there's no one-size-fits-all treatment.
Now, get ready for this number because it is staggering. An estimated 90% of people living with ME/CFS are undiagnosed. Just let that sink in. That means millions of people are suffering without answers, and a lot of them are coming to our pharmacies looking for help with their symptoms. Our awareness can literally be a turning point for them.
So, how is this illness actually diagnosed? This is a huge challenge because there's no simple blood test or brain scan that says, yep, you've got it. Instead, it's a clinical diagnosis, which means it's all about recognizing a very specific pattern of symptoms.
So what exactly is that pattern? What are the non-negotiable symptoms a clinician has to see to make that diagnosis?
All right, so according to the National Academy of Medicine, a patient needs to have 3 core things. First, a major drop in their ability to function, along with fatigue that's lasted more than 6 months. Second, there it is again, post-exertional malaise, that crash after activity. And third, unrefreshing sleep, meaning they wake up feeling just as tired as when they went to bed. Then, on top of those 3, they need at least one more, either cognitive impairment, what patients call brain fog, or orthostatic intolerance.
Okay, so once a diagnosis is finally made, the whole approach to care has to do a 180. We have to shift our mindset away from looking for a cure.
This might be one of the most important counseling points we can ever give a patient. The full recovery rate is tiny, only about 5%. So our goal isn't to chase a cure that right now just doesn't exist. Our job is to help patients manage their illness and improve their quality of life day by day.
So the goals are pretty clear. We want to relieve symptoms, teach patients how to manage their very limited energy, and, this is huge, validate their experience. So many of these patients have been told for years that it's all in your head. Just acknowledging that their illness is real, that can be powerful medicine.
And that management, it doesn't start with a prescription. It starts with foundational lifestyle strategies. Honestly, this is where you can have the absolute biggest impact.
Pay attention here, because this is probably the most critical counseling point to prevent actual harm. The recommended approach is activity pacing. This means helping patients learn their new, lower energy limits, their energy envelope, and stay within them. We must strongly advise against something called graded exercise therapy. Pushing through the fatigue, trying to exercise your way out of it, can cause severe, lasting crashes and is now known to be harmful.
So when you're counseling a patient, you can explain pacing with these simple steps. It's about breaking big tasks into little pieces. So instead of doing all the laundry at once, maybe just do one small load. Then take a break. Put it away later.
The whole point is to break that exhausting push-crash cycle by learning to respect the body's new energy budget.
Beyond pacing, there's more we can do. For that dizziness when they stand up, you can counsel them on increasing fluids and salt. For sleep, we can reinforce all the good sleep hygiene we already know. And with diet, it's important to manage expectations. A healthy diet is always a good idea, but there's no magic bullet supplement that's proven to work for everyone.
Okay, now let's get to the medications. The key thing to remember here is that we aren't treating the disease itself. We're using medications as tools to manage the individual, most disruptive symptoms that the patient is dealing with right now.
For orthostatic intolerance, there are a few off-label options. First thing you'll notice, the super low starting doses. With something like propranolol, you have to watch out because it can actually worsen fatigue. With midodrine, a huge counseling point is the risk of high blood pressure when they're lying down. And pyridostigmine is an interesting one, because some evidence suggests it might even help a little with exercise capacity.
For pain, you might see low-dose naltrexone, or LDN, which is gaining traction, but you have to counsel them that it must be compounded. For sleep, if hygiene just isn't cutting it, short-term use of antihistamines is an option, but be extremely cautious with tricyclic antidepressants. The doses used are way lower than for depression, but the risk of sedation and orthostatic hypotension is sky-high in this sensitive population.
All right, let's pull all of this together into a final set of key takeaways for your practice. What do you really need to remember?
If you remember absolutely nothing else from this, remember this phrase: start low, go slow. Patients with ME/CFS are notoriously, exquisitely sensitive to medications. The standard starting dose for a healthy person is often way too high for them. We're talking a fraction of the normal dose, titrated up very, very slowly. And always ask yourself if a new symptom could be a medication side effect because they overlap so much with the illness itself. Suggest vitamin D, since these patients are often housebound and not getting sun. And know that conditions like fibromyalgia and POTS are common travel buddies with ME/CFS. And finally, never, ever underestimate the power of just listening and validating their struggle. It matters.
And one final word of caution. It seems like it would make sense, but stimulants are not recommended for managing fatigue. They just lead to a bigger crash down the road. And while a benzo might be used very, very carefully for a severe crash, regular use is a big no-no because the risk of dependency is just too high.
Look, this condition is devastating, and these patients are in our communities, walking into our pharmacies right now. The question really isn't if you'll see someone with ME/CFS, it's when. So I'll leave you with this thought. Now that you know all this, how will you change your approach to validate, to protect, and to truly support that next patient who walks through your door? Thanks so much for your time.